that thing. It'll be able to see us. I'm going to cover all the aspects, including that of the pump itself and each detail that is entailed with that. We're going to go over just a small scenario, nothing crazy. Remember, this is the beginning of all of the wet labs. So we start off at the very basic and we're going to work our way up to the most difficult situations itself. So we all know that ECMO can be completed, obviously, in the operating room, in the unit, other than the CVICU. It can be an ECPR, although we don't call it ECPR here at WU because we're not a big enough program and we don't have all that experience. So we just call it emergent cannulation, or it can just be in your typical controlled environment. So we see that a lot now with our COVID patients, right? Because we bring them in already expecting to cannulate them. No matter where the ECMO happens, we just need to understand everyone's role, which is very important. So I know that sometimes as a new specialist or anything coming along, whether it's RT or RN based, it's hard to step back from that role and realize that you're in a whole different gamut now. So you're no longer touching the IV pumps. You're no longer going to get the patient. You're no longer touching the respirator, the ventilation system. You're not doing anything like that anymore. You're now in the role of handing up the surgical supplies to the tech. You're now in the role of starting the ECMO itself, going along those lines. But remember, in the room, there's tons of people, right? So you have your perfusionists, you have the doctor, you have respiratory, you have nursing, you have, who am I missing? Sometimes the CAs are in there. It's pharmacists. Galen's been coming in, which has been great. So everybody wants to be part of that. And there's all kinds of key players that take part in this, what could be a fun thing, but can be also very traumatic at the same time. So I just have a picture up on the screen. I know you guys can't see it, but it looks like what you would want, a very clean environment, but what ends up being is absolute chaos inside an ECMO room. We all know that. Everybody always wants to come in. You have students, fellows, everybody wants to be a part of it because it doesn't happen that often. And when it does, and if you're there to be a part of it, everybody tends to jump into the room. So when it comes to an ECPR type situation or an emergent cannulation situation, it's going to be run just like any normal code would be. So you're going to do everything that, you would see in a normal code just outside of your spectrum. So it's not a nursing one or an RT one. It's going to be based off a specialist one. So that's bringing the rainbow cart to the room. That's bringing the ECMO supplies to the room. So making sure you grab the primed pump, the rainbow cart, any cannulas or supplies you need. When you get to the room, your hospitalist, your intensivist, whoever's running the code and the nursing staff and RT, they're going to be doing exactly what you would think you're accustomed to doing. However, you're entering a different role, right? So you're going to be setting up the supplies, all the sterile supplies. You're going to be getting all of that ready. Checking through your circuit, making sure that it's good to go, getting your medications if need be. So these are all different roles that you have to identify that each key player is doing. Now, if you're like good and you feel like you're confident, you have everything set up, and you have plenty of time as far as your cannulation is concerned because you're in a controlled atmosphere and the nurse asks you to hand her something, obviously we're a team, right? So we're going to help each other out the entire time. It's nothing different than if you were, as a bedside specialist and your nurse asks you to pull the patient up in bed. We're a team, so we always help each other out in that respect. But you just have to be cognizant enough that all of your supplies are ready to go in the meantime. Because you don't want to be caught and Dr. Hank asks you to hand up the cannulas and you were too busy helping nursing or RT staff that you forget what's really important in that respect. Let's see. The rainbow cart. On top of the rainbow cart, there's surgical trays that are necessary for the surgeon. So you always need that little blue tray and then you'll always need the big blue pack. Perfusionist has to come in for initiations and for cannulations. Once they arrive, and they get a 30-minute window, so once they arrive, they'll do the complete and final check of the circuit, ensuring all of your connections are tight. Everything's ready to go. You have it completely de-aired. You have all the supplies that you need to go on ECMO, and then they essentially tend to take over the part of the pump system while you're handing up the supplies to the surgeon itself. What's really nice about this is that you, as a specialist, are cross-trained to do both. So if you decide you want to do the pump, the perfusionist can hand up the supplies. It's all in what you guys are in touch with and comfortable with. Just make sure you communicate with each other. If you haven't worked with the Novolung in forever and you're like, I want to go on ECMO with the Novolung, I want to do the pump part of it because I haven't done it yet, just say that to your perfusionist and work with each other in that respect. And if you have obviously any questions or concerns throughout the entire time of initiation, just ask us. That's why we're there. We're there as an extra set of hands. It's safety all around, so that we can get on quickly and adequately to get the patient in a better spot than obviously what they're at. Nursing and bedside nurse, charge nurse, all the extra staff. Remember, you guys are the ones that are controlling the atmosphere in the room. So if you start to freak out, all of that extra staff is going to start to freak out. If they notice panic in your face, they're going to notice that something's going on with the circuit. So try to keep as calm as you can and collected. Don't yell, don't get abrupt in any way. It's easy to get excited and stressed out in these situations, but just know that we're all there to help you and support you. That's why perfusion's there. They can jump in quickly and act fast to help in any situation. That's what we're trained, what we went to school for. And that's what you guys are also trained to do. So as a team, you guys can come together, fix the problem, make sure everybody knows what's going on, speak it out loud, don't be afraid, and just keep moving on. Let's see. Always remember that wet labs are a judgment-free zone. We're all here to learn and work together, achieving the goal that's handed to us. So that's why we have wet labs, so that we can always come together. Post-simulation, we'll talk about any reactions, description, analysis, or summary. I have to say all this with wet labs, so I apologize. We'll discuss all of that and go through each step. If anyone has questions, we'll go through those as well at the end of the wet lab. So right now for this wet lab, we're just going to go through the circuit itself and how you hook up all of the cables in the back of the circuit. So we'll start with the center mag. I have the center mag and the cardio help here with me. So we'll go through each of those, and then we will, I don't know where Adam went with his fancy little phone. And then we'll do questions along the line. So if you guys have anything, just unmute yourself. We can hear you in the room, and we can show you closer up if you need to. It's hard. This is all new doing it this way, so I'm sorry, but thanks for joining. All right. Oh, well, got a quick PowerPoint presentations, right? So let me go grab the fancy phone.
I don't see it.
Thanks, pal. Do I have to turn this down? Or do you turn that? Oh, there you go. Okay. Thanks. So on the back of the center mag circuit, you have tons of cable connections, right? So if any of these come loose at any time, you need to know how to hook it back up. If you need to move any of your cables from one pump to the other, you have to know which cable goes where and how to connect that, right? These flow probes tend to always get loose. So there might be times where you see you have no flow and you're like freaking out thinking I need to clamp out the circuit quickly. That's not always the case. Always check the most simple things first. Make sure everything's in here nice and tight before you just clamp out a system in its entirety. If you see your flow still going, you still see color change, but you're not reading flow, you know your patient's stable, right? So always check your pressures. If your flow all of a sudden is stopped up here, but you see color change, pressures are fine, everything's maintaining, you know that it's something going on back here. Maybe your flow probe itself is loose on the circuit. And these are on both the cardio help and the center mag. So always double check to make sure that your connection on the back of the circuit itself is nice and tight. So although you have a sheet here, there's cables just laying around, and I need you both to just connect these cables to the right spots that you think they go in. So that's your screen cable, right? That's what's going to give you a reading on your screen. And there should be a red dot at the top, and you just push it in to connect. Perfect. Always make sure your power cord's nice and tight. It would alarm if it wasn't in, and you would hear it reading like the alarm for battery on battery mode. So you just want to make sure that that's nice and tight and in, and that the little bracket is pushed down around it. Next, you have your pressure cables. So obviously, if you have to move these down, P1 and P2 are respectively labeled underneath the cable itself, the connector. So you just want to make sure you connect the right one to the right insert. Yeah.
Where's our flow probe at? Is there another one? Or
There is. So every console will always have its own flow probe. It's tricky because you have to measure up because there's different angles at the top and bottom. And then you have to make sure that you screw it in nice and tight. And this is where it could come loose because if someone doesn't screw it in, you can feel it just wiggling there. And it's where you would get your inaccurate readings. And then you have one more.
This is not.
So that would be your pump motor. Perfect. Now with this current setup, the way that it is right now, if you had to jump from this down to that one, do you have to do anything?
Not immediately.
What do you have to move or switch? If this pump motor failed and I needed to move down to my backup, what on the back of this system would I need to switch out?
Switch the pump motor to these two.
Nope.
No.
Nope.
Or
What cable wise would I have to switch out? What is on one circuit?
the
that
pressure,
isn't-
the pressure
exactly.
cable.
So your pressure cables you would have to
Okay, so
move,
you're
and
saying
then
you're-
what else would you have to swap? If I'm moving from this system to this system, going from here to here, what else would I have to move? There's one more thing.
Well, the monitor you wouldn't have to, right? Because they're both plugged
Mm-hmm.
in.
So that one's fine.
The motor you don't.
How are you gonna
so-
read your flow?
Flow probe.
Good job. So you'll have to
Yeah.
switch your flow probes, right?
Yes,
Because this
If you
flow
want.
probe is connected to this console. So you
Right.
need to make sure that you use
you would
the-
just take this
the
one
right-
out and put that one on.
Exactly.
Okay,
Yeah.
gotcha.
Yeah. So you would want to swap that out quickly so that you can make sure that you are flowing adequately to the patient and that you're not achieving anything other than. And you want to make sure you remove your pressure cables so that you are not doing super high pressures or super low pressures, pulling super negative. Does that make sense?
Yes.
Cool. So that's that system. Now in the cardio help system, if you had to flip from here to here, you know that you have to disconnect these cables that are running, right? 'Cause this is a hand crank. It's not an integrated computer system similar to that of the cardio help. This is just a simple hand crank. You're doing everything by hand while reading at the top. The cables for the back of this, obviously you can take them out, very easy, simple, put it back in, match red to red. And then you have the SVO2 cable. Again, just push the button to take it off. It's another one that you can just pull right out and then you can stick it right back in as well. The problem with the SVO2 cable is that this cable is calibrated to this machine. So this has to always stay with this one. It's not interswappable. I can't take this one and put it with the one upstairs. Does that make sense? So if this one were to break, it gets sent back and then it'll get recalibrated to the same system that it came with. Everything else we can take off and interchange whatever we need to do. Whenever you're done, obviously, you move this up. You're just going to end up dropping everything, putting it onto this, and hand cranking away. Do you need your flow probe whenever you're hand cranking?
Well, if the
It's
cardio
not-
helps broke, then I don't think it would.
Yeah.
No, so it doesn't matter.
Also, something else you don't need is the water. You can actually undo the water
Mhm.
to the thing.
You would have to because it goes up and under. Your water bath does, so you'd have to undo your water bath, move up to here. But your flow probe, you don't have to worry about like you do this one. You don't
Right.
have to move
Okay.
it to the next one down, right?
Right.
Because you can read your flow right up here at your RPMs. So as you're spinning it, it actually gives you your flow reading. So a lot of people always get that tripped up because they think, oh my gosh, but we don't have our flow probe. We can't read our flow. You know, that's why you have this dial set up at the top so that you can make sure that you're giving 5 liters of flow or 4.5. It only goes up to 5. So if you can hand crank faster than that, that's pretty impressive because it gets very exhausting.
Okay, I have another question.
Yeah.
When you're going from here to here, I've seen a couple times where just through things I've watched or whatever, one segment they clamped out and moved it up, and
Mhm.
another segment they didn't.
You don't have to. I would
Okay.
clamp just in case something is going on
Right.
interstitially and
sides.
you pull.
And
You can
okay,
just clamp arterial side and
Okay.
just move it right up. You don't have to do both.
okay.
in best practice, you should clamp out and then move
Okay.
up. Because what if you pull something? What if there's air being entrained? Why did this shut down to begin with? So you have to think of all those extra preliminary things.
Okay.
Why are we going to our hand crank? What's going on with our patient? And if it is something that would be related to air or trauma, anything along those lines, if something happened to the circuit, it's just better to clamp, move it up here, unclamp, and start going to town. But it's not an end all if you don't have time and you
Right.
just make it move as quickly as possible. Because right, you just want to get the patient back on safely, but you also don't want to pump and pull there. So just being cognizant of that. I always clamp arterial side because if there was any air coming down my line or being entrained, it prevents it from going to the patient, right?
Mhm.
You can clamp your venous side, but who's to say that you don't have air somewhere? It's hard to see in the cardio, so who's to say you don't have air somewhere in there? Now we do have the air detector on with the cardio help, which is nice, but we don't have it on the Centromag. So it's just easier to train all across the board to get used to just clamping out that arterial side or post oxygenator side anywhere so that you don't have to worry and you're not even thinking twice about it. Always try to develop a good flow in your own head of how to react quickly to any situation the same way so that you know that you're not going to be like, oh, it's the cardio help. I don't have to worry about that. Because in those stressful, high, tense situations, you end up forgetting like a hot second. So if you just stay with the same mentality, you'll be on a good pace. All right, so let's get, I think I have a cardio help. You just you can just sit that down if you want. I'll put this together. You want to practice moving the cardio help?
You want me to pull this stuff off?
We're gonna use it on
Oh,
the framework. Yeah. So here you go. You can put it in there. It's leaking, so just be careful. That's why I didn't want to prime this one. Damaged.
Oh,
It always has to go in, and then
Come on, quick. Perfect.
you want to hook it all up or just?
Yep. So hook it all up as if you're going to be on ECMO. What's nice about the cardio help is it's the same type of priming mechanism as all of them with the reservoir, but it's a bag, but it primes really quickly.
Do you want to go ahead and put this on? Or
Yep.
just put it on here?
Nope, you can do it all. Put it on. Perfect. And then your flow probe. Nice. Okay, now your pump malfunctioned. Everything's going down. You have no power. Your patient is currently off ECMO. There's some clamps on here. One. So now you have to move up to your hand crank.
so say I clamp out.
And what's the other thing that you'll have to do prior to moving it upwards? It's not on there because we don't have any extra ones, but what about your water bath?
Yeah.
So you would be disconnecting your water bath
Oh, okay.
You could
I gotcha.
disconnect the water bath
and just lay it there.
and then disconnect this. Well,
And just
we're in
lay
an
it.
emergency situation, so we're just gonna throw it under there.
Yep. And then Lane, how you put the arm up, that was good. So it's actually like a rock in motion.
Yeah, I'm kind of having trouble with that.
No, you're good. Take your time.
This thing's not going down. This thing, it should.
It has to like.
There's a little lip under there that fits right there.
And it goes right
It's right
here.
there.
And then there's this slip and it goes right
So put that lip on there.
there. Now you should be able just to push it right in.
It's. I don't think it's in.
Yes, this
Oh,
way.
yeah.
It's in. So then
Let's move that out. For the whole line.
it's where things go through a lot sometimes. So all of a sudden we're able to get this powered back on. Now you can move this back down.
Okay.
So you're not going anywhere.
Yeah, we're-
There. Really got cranky with it. You gotta keep going. Jeremy, do you want to try? Would you like to try and see what it feels like to crank?
I think. you
Yeah,
gotta
because
crank
you're
it
kind of going up and
single-handedly, you can
down.
crank
You
it.
were
Yeah.
the crank guy during our training.
This is not, but this is RPM. You said the first is like flows. This is
RPM times 1,000. Here's the
So, like,
flow.
this
1,
is-
2,
isn't
3,
this, like,
4, 5.
3,000 RPM,
Mhm.
3,500 RPM. So it's not like saying your flow is 3.5. If you-
No, you just want to make sure that you're flowing high enough as at an RPM rate to achieve.
So like you'd go.
So if
by.
you were at 3,500 prior to even shutting down and you were flowing at 4, you would have a good
Idea of where you're going.
idea. Yes, exactly.
Okay, so we're going
Alright,
back.
so
So
we're
now
going
we're
back down.
back. So you're gonna want to move back down. Good. Clamp off.
This sounds like a little.
Switch. You should be able to push it back.
Okay.
It's
It's a little sticky, like.
Can I just show something here real quick?
Yeah.
Okay, so I was playing, moving it up one day, and when it comes out of the package, there's like a piece of tape right here. And I was having trouble like actually getting it on there because that's supposed to puncture the tape, but it didn't. So I just ripped it off.
Yeah. No, that's great.
So if you can't get it on there, that thing might not be puncturing your tape. Just rip it off real fast.
Gotcha.
Just a little FYI.
No. Thanks.
All right, Jeremy. You wanna do that?
Perfect. Make all of your connections. Now, once Lena makes this connection, you can go back on and because you'll probably want to recalibrate your SVO2, right? Because it's been off.
Right.
You're gonna have different settings anyway. So I personally would just leave this off, unclamp, and go back up on my flows accordingly.
Okay.
I would stick this back on and send for lab work so that you can recalibrate it and then put it back
Okay.
on so it reads what the patient's actually doing now.
This wouldn't hurt any. You know, like it wouldn't. It would just be wrong.
Yeah.
Like okay.
Yeah,
Gotcha.
yeah. It'll just alarm just like it does now whenever you have the low SVO2. You'll just get that reading or that continuous crap will happen until you get it recalibrated.
Okay.
Plus you want to have the best reading. This equipment's very nice to give us all of that data, so it's good to go through. So now this one, this is a sterile cycle, so it's a little bit more difficult. But now I want you to move this pump down to here and then move those supplies, these cords to what you need to do.
Okay.
Remember, you're always going to be with somebody. You'll never be by yourself. So, sorry, we use Yeah, they all work the
Is this
same.
thing loose? Yeah.
Is it gonna fit?
It'll reach.
Here, move this down.
Because on the real patient, it would probably be the
Oh, yeah, you wouldn't have it hanging up too much.
No, it's been a while since I've done this. I thought you have to line up these little divots, right?
Yep, and then turn
And then, and then turn it
downwards.
downwards.
You would go down, yeah.
This doesn't seem like it's, okay, there we go.
And then what's the other part of that that you always want to make sure is done when you're putting that pipette in?
The direction of
Yes.
the outlet
Yeah.
you
And
want
you
to
want it
be
facing upwards. Because
upwards.
air goes to the path of least resistance. So if you were to get any air in here, you don't want it sitting at the top of your pump head, right? You want it to be forced up and out to your oxygenator.
Yeah.
And then if that were the case, you would always want to remove your yellow cap so that the air can be released out of the oxygenator.
Okay.
And obviously, if you did have air, it would get real foamy in here and you would see it trickling out. Okay, what else do you have to move? You just move down to your bottom pump head.
I gotta move the pressure transducers.
And then we now have you move everything back.
And the flow probe.
But if you can't get your flow probe on quickly enough, what can you identify with? Make sure that you are flowing. You can go up on your flow, on your RPMs.
Color change.
Good job. Because our ultimate goal is to get the patient back on, right? So move it down, go up on RPMs, identify color change, look at your patients, monitor, make sure they're hemodynamically stable. All right. Then you want to move it back up. Move all the cables back up. Nice. Sure. You guys have any questions about that? Does anybody have any questions up on Zoom yet? Everybody good? Nice. Okay. The other thing, obviously, is building and priming the circuitry itself. So, because we don't have any open available circuits for this portion of it. I just have a dry circuit here, so we're gonna just set it up on a table. You guys are just gonna piece it together, which actually in turn makes it kind of hard. But thanks for being so nicely. Actually, you can cut a bigger piece of. All right, let me push this away. We'll use this table right here. And there's a box of fun pieces right here. So you're not exactly giving it nice and pretty, which is kind of fun because it teaches you what to look for. Situation, right? So I want you to build the circuit as you would long ways along the table. No, we can do it on the bed, so you can utilize this as if it was your patient.
Getting credit for a wet lab, so I already know how to do this. I'm playing on my phone.
Live?
Mm-hmm. Yeah, third one, the steps lab.
What are they doing?
building circuits.
Okay, yeah, this does make a difference.
Doesn't it make it more
I
difficult?
just got all these like.
If you can do it like
If
this,
you can do it like this,
anywhere. This is
exactly.
like doing it in the desert.
So it's just like remembering the factor of all the cables that are connected to the circuit, right? People always tend to forget about these things. So then you tend to forget about how easy it is or how hard it would be if you just had a box full of tubing. How would you build this circuit without having that part? Give you a better understanding of how it would be connected.
Get all the relevant tubing out of here.
So
first.
let's pretend
All right,
let's make
so
this easier for you. So here's your patient, right? And we'll pretend that this box is your patient. So here's your arterial line, obviously red, and your venous line blue. Good?
Okay.
So I'm coming down from my venous line. What am I connected to?
Okay.
You're gonna
Good job.
actually connect it to the pump head.
Good job.
What are you doing? Watching a wet lab, so I get credit for it.
I can do it like with
I'm
this,
passing it in.
Sit right up here.
because that to prime it, you'll need
You'll need this.
you'll need
piece.
that part.
So we can just pretend. So this piece would actually be,
Minimum of 2 wet labs a quarter.
we'll just go from there. Okay. So now from your pump head, what's the middle?
I build a lot of circuits. I'm pretty comfortable building circuits, so paying attention. Build more than you. So
So which side is the venous space of the O? What's the red word? What's an easy way to identify
but
There's the
the
yellow
venous
cap.
space? Yes, the yellow cap at the top.
Trying to think on the fly.
You can also think that there's
Wait,
the middle.
it says blood in and blood out.
Yeah.
There's that.
So
I
you've
always
got
look for
blood in.
this piece is always in the front facing forward.
Which
This is hard
piece?
to see. You have this middle
Oh, okay.
adapter piece. It's your quick prime line. So you can actually attach this. It's a line that looks similar to this. It comes with the mechanic screws right on. Yeah. So this is what they call quick prime line. So if you were to become so de-aired, you could actually hook this up in here, and there's a valve in here. So once it pushes in, then that's when you allow it to flow. So you would hook that up in there, like such. Disconnect your arterial line from your patient, spike this up, and it would fill that. And you would just flush right out of your arterial line. If this were to get full of air, though, however, we don't teach this because it is just much quicker to get a brand new circuit. Brand new circuit. If you have that much air that is taking over your entire oxygenator, it's going to be foam. It's going to take you forever to get it out. It's not worth the trial
Yeah.
in air. It would take you way too long.
Kind of risky for your patient.
Exactly.
All right, so blood in.
Yep.
All right.
And then this is gonna go. We're missing a couple of pigtails.
Okay, so where do our pressure line pigtails go?
It's 2 lower connectors.
So which one is P1 and which one is P2?
This would be P1. This would be P2.
Good job. And then on the back of the centromag, you know where to identify P1 and P2 are.
Well, we just are saying.
Now we're leaking everywhere.
I'm sorry, what was your question?
You know where to properly identify P1 and P2 on your circuit. Correct, on the back of the console.
Right below the blood.
Now, if this were to happen, say this were to become disconnected, just for a fun giggle, like it just did. You have this hooked up and running. What would happen?
It would be,
If it got
Injecting
disconnected,
blood
you'd be
out.
like spraying blood.
You would be
everywhere.
spraying blood. It would be pulling
It would be
from the
ugly.
patient going on the floor.
Right.
But would you be sucking any air in through here? You're on VV ECMO.
no.
Why not? Your heart's still pumping, right? Still ejecting. Would you still want to clamp this out?
I would,
I would.
yeah, certainly.
Exactly.
I mean,
Yes.
I don't know if you'd suck, you might,
Yeah.
depending
So
on.
you would
your
wanna
patient's,
clamp?
Like,
Both sides, correct?
Right.
yeah,
Reconnect here as fast as you can, if possible. Make sure that it can be aerated. or get a whole new circuit, cut it all out,
Yeah,
throw this away, because if this fell off, then there has to be something going on here, right? It wasn't on tight enough, maybe this tubing got spliced somehow along those lines, so you have to really evaluate the situation, but you would want to plan this.
so let me ask you this, if, say your tubing did split like right here,
Mhm.
okay, and you had it zip tied on, would you just clamp out and then like cut and then reconnect it, like wet to wet reconnect it?
Yep. And then what would you want to check here? And what else would you want to do?
Check for air.
You would want to make sure connector's not cracked. This is split. Was this cracked as well?
Make sure the plastic's not cracked, you're saying.
Yeah, and this comes already pre-connected. So if this is cracked in some area, you're gonna have to replace the whole oxygenator.
Okay,
And you want to take off your yellow cap because if there was any chance of air being in there, you would want it to escape through the top and not go to the patient. Before coming back on to ECMO, you would want to make sure that your front side is also de-aired. I don't know if you guys ever noticed this, but when you prime this oxygenator up, there'll be like a clear line here. And you always have to take this cap off, or where you, there's actually a pigtail here, but you always want to vent this out because then the fluid will actually rise up to the top. But typically it doesn't prime very well on this side. And then when you go on, you end up sending all that air forward, or whenever you're getting the pump set up ready and this isn't primed all the way.
so when you
It's a
prime,
quick line.
take both of those top.
I always take this
Halfway.
off, and then there will be a pigtail here. So this pigtail will be there, and I'll just put a syringe on it and pull back. And also because it's positive pressure, right? Coming through, because you're going to the arterial side, you can just take the cap off of the pigtail that's hanging here
Okay.
and let it positively
Yeah.
prime forward. That always works. But anytime there's any type of air entrainment, or even do your cytosol hookup, your plasmapheresis hookup, anything, I always take this cap off. Because if there were any chance of air to hit this oxygenator, it's going to escape through that membrane port versus going forward to the patient. It's just like another little extra precautionary move that you
So
can
it
do.
doesn't matter, like, even if you suspect anything, you can still take that off.
You can take it off
I mean,
anytime.
it doesn't, you can take it off anytime.
Mhm.
Like, okay, so if you put somebody on pump, isn't this supposed to be off for
Yep.
like an hour or so?
It doesn't matter time frame wise. You can leave it off for 15, 20 minutes and then
Okay.
put it right back on.
Okay.
There's no time frame, and regardless of it, at my last position, we never put it back on. We just left it off the whole time. Some centers say that the accumulation of plasma that builds up in here causes it to block. So then when you do need it, an emergent need, you don't have the capability of the air escaping from that port anymore because you actually blocked it off with that plasma leak. If you ever leave it off, you'll notice like a yellow tinged plasma leak come through here just from the pressure. So that's why we put it back on, just so we can keep it so that it is a good porous membrane for air escape. That makes sense.
Yes.
Yeah. So is this hollow or not?
It's a closed cap.
Gotcha. Okay.
Okay. So you know where to put your pressure lines here. You know that there is this port here. There will always be a port that we have to cut in on this side, and then you'll have the pigtail pump head as well. Now, why do we have the pump head pre-pigtail? Or the pump head, sorry, the pigtail pre-pump head. To hook up with.
We hook up cytosol on that side,
Exactly.
and sometimes we hook up CRT. Some people prefer to do it like that.
And why do you think we need that negative pressure sometimes for CRT or essentially for the cytosol?
To pull through, to have that pressure pulling back into the system.
Exactly, so that you can cover the entire surface area and you're able to do it and you're not competing against positive versus positive. Is it the safest way to do it?
No.
Not at all. So it's one of those last ditch efforts.
You're saying it's like if it's alarming, like the
Mhm.
return is too positive.
Exactly, because with CRT or plasmapheresis, sometimes your flow is so high on these patients and you need to achieve that surface area volume. But there's no way that you can compete positive to positive, right? So you have to
Right.
switch from positive to negative so that you can flow at the higher rate. If you were to slow down your flow, I think it's on CRT and on plasmapheresis, it takes so much longer. I know plasmapheresis, it takes so much longer. CRT, I can't really speak to in that perspective, but I know with pheresis, it would take them a longer amount of time to actually get the goal that they're achieving of the complete, I call it human oil change, but that aspect of it. On the cardio help now, Where are we hooking everything up? So if I were to put a cytosorbent line here, where am I hooking it up at?
So we don't, there's a pigtail like right on the arterial face and then this one back here.
So we actually cut in the
Can't you
pigtail
cut
for
in
that one as well.
pigtails? You have to like cut in pigtails on this. Because the cardio help I had the other night had these two, but then they had a pigtail here and a pigtail here.
So for
I had to
having,
flush for pigtails.
I use these two for CRT or
Right.
plasmapheresis rather, but
Exactly.
the cytosorb needs to be hooked to a
It
negative.
always has to be hooked from negative to, or positive to a negative.
Yeah, so we would hook
So-
up somewhere here and then go to the pigtail.
Exactly. Which one do you think is safer?
This.
Good job. So this one we would always obviously hook up, follow your arrows. So you're doing positive pressure up to your negative port where it's sucking it through. That's just so you can touch the entire surface area of the cytosorb filter itself. Now plasmapheresis, where are we hooking up our pool line? So we're going from our system to them.
Access from this one.
So I drop, and then where are we returning? And why do we do it that way?
So if any air comes through, the oxygenator would catch it.
Good job. And then whenever we hook those up, you know that you can put a syringe on the back and have it flush into the syringe prior to turning it on. It's the same thing with the cytosorb. Put a syringe on your negative line and have it push positively up through. So you're going from your positive line up through to your negative line, but it's going to go into your syringe first. So you can check for any last ditch air. And you should do that with both when you're making your Prismaflex connection, whether that's CRT or plasmapheresis and your cytosorb connection. Okay. And that's the same with this circuit. That's the same with this circuit. So even if you were going to be using this circuit with cytosorb or plasmapheresis, where would those connections go on this oxygenator?
For
For cytosorb
For cytosorb, we can start there.
here and then back to here.
Nope.
Here and back to here.
Yeah, exactly.
Okay, because it's before the
Mhm.
oxygenator. Okay.
Yeah,
gotcha.
you have that access port where it's before oxygenator, just like this one.
Okay, so
So-
for plasma exchange and CRT, you would do it here.
Yeah, you would go from here
To here.
to there.
Gotcha.
Exactly.
Okay.
Makes sense.
Yes.
On the Nova lung, which I have over here, we just didn't have a system available, or I would have brought it down. Nova lung oxygenator, where are we connecting?
so zero this one to this one. Access.
You'll go red to blue.
Access return.
Exactly.
And then do we hit the button?
There's. Your lights off then.
So we would have, you're saying we would have a pigtail
Yep,
here, so then you would go from this one
Yep.
to pre-pump.
Yeah.
yeah,
The
you would
blue
have a
line.
pigtail right
We
there.
have pigtail somewhere
Yep,
with the cytosorb.
Right.
exactly, yes.
Okay.
And again, why would we want to return? Or
Be-
go from
It's
here?
pre-pump.
Good job, because it's air. You don't want to obviously
Yeah.
pull anything that would be directly close to your return outlet, right? It's the same as your quad drops. You don't want to return anything to red or pull from red. So air, it's just quicker to get to your patient. You do anything where it's, pre-arterial, it's your best bet chance. Questions about that? The Nova lung and the cardio help obviously have the bags that we prime with. You do the spike prime and then you do that quick drop prime. On the Nova lung and the quad drops or enzymatic systems, you always want to clamp post pump. Everybody does differently. You do whatever way you feel more comfortable with. I always clamp post pump head, drop my fluid and de-air this line as best as I can, right? So I smack it, fill this up, smack this, get this all de-aired. I open up and I let it gravity prime. Always let it gravity prime completely to the best it can go. Usually it can go up to here if you drop this on the ground. Then turn it on and let it circulate back up to your reservoir. take your caps off, take this cap off, and then walk your way through. Use your syringes. You have positive pressure, so you shouldn't be able to really have to pull anything here. It should just force itself through, whether that's gravity or the pump being on. And just keep working your way through. Start at the beginning. Like I always say, start at venous, work your way down all the way up to your arterial return line. The reason being for that is so you don't miss anything. Prime your transducers before doing this. Do you know why?
Prime your
For this
transducers
system.
before doing what?
Prime your transducers before dropping this fluid and priming your circuit. Why?
So you don't put air in.
Exactly. So if you just prime your whole system and now all of a sudden we're gonna prime
Yeah.
these up and they're hooked up, you're pushing all of that air that's in these lines right into your oxygenator.
Yeah.
So then you're gonna have to sit there and get that to your. The same goes with the Novolong. Only these have this, so you don't have to worry about that, right? So it's different than the cardio health. You don't have to prime any pressure transducers, right? Because it's all connected with the computerized situation there. So the only one you have to make sure that you prime prior to dropping the rest of your fluid is your Centromax system.
Hey, Jamie,
Yeah.
if you use a Kobe connector like they use for the art lines and you put it on your oxygenator, you can prime the Kobe connector. And then if you forget to prime your transducers, you don't get the air in the system. So you put the little 6-inch Kobe connector right onto your oxygenator.
Yeah.
And then and if you need to change out your lines, if they're outdated or whatever, you can change them out without having to disconnect it from the actual oxygenator.
Oh, I don't even know what a Kobe connector is.
It's like
I'll
just
show
like
you.
a transducer extension that's like this long.
Oh, okay. Is it on here?
No, yeah, it's a separate piece.
Oh,
that we
it's a
stock.
separate piece.
Yeah, so like whenever they insert an art line, that's
Yeah.
like the part that goes from the arterial catheter to the pressure tubing. So
And
the
it just
pressure
has like a
tubing
one-way.
I think it has just a stopcock on it.
So then would that stopcock also be on the oxygenator, or you remove
I
it?
don't- I don't
Yeah, the
remember
stopcock would stay on, but it's like a 6-inch pigtail. So that pigtail goes right on the oxygenator, and the stopcock is hard attached to it. It doesn't come off.
But you
So
would have
you-
to take that off after priming it, right? Because you wouldn't want that stopcock connected to the oxygenator.
Well, it gives you the ability, if your transducer set goes bad or whatever, you can change it out at that point in time, because you have a place with the stopcock that you can change it out.
Oh, I see. Because you could turn it off to the system.
You can turn it off the system, yeah. Or if you get air in your lines and your transducer lines, you can get the air out there.
Right on. No, that makes sense. I'll have to check that out. Thanks, Matt. Do you guys have any other questions? Jerry, Dan, Allie, Amber?
No, thank you.
Was there anything that we didn't cover that you guys would like to see?
I don't think so.
No? Is there anything that you guys want to do? No? Are you good? Is that a good little overview for you?
Yeah, I mean, I kind of need a little refresher, so.
Oh, of course. The next sweat lab, you're actually in a building prime
Yeah, I'll definitely.
circuits and then setting up sterile supplies. This is just so you understand how this all works.
Another thing too, maybe to mention, like I've always done this when priming pressure transducers, but I've seen not all the time that it's like that when you spike your saline bag in there, you turn it upside down and then prime with the bag upside down. So all the air that's in the bag from the manufacturer then comes out.
Comes out.
Yeah.
I
So,
see what you're saying.
so what happens, like you have this little bit of air in here.
Yeah.
And if this bag runs out and there's still pressure and like keeps getting pumped out, that's gonna push through. You know what I mean? Whereas you can
Oh yeah, it's like your reservoir bag.
prime it so that it's totally air free, so that once it's empty, it's just empty. There's not air
Yeah.
come through.
They actually say to do it that way too with the cytosol when you're priming it. Whenever you spike your bag to fill this completely up with volume so that you don't have the ability to put any air in that cytosol.
Yeah.
Once you put air in this, as you can see, 'cause this was deprimed, it's trash. So that's $1,900 to throw away. Or
It doesn't. I mean,
$1,600.
it doesn't even have to be the like bag's empty too. I mean,
Yeah.
I've gotten admissions from outside and they have an art line or whatever, and then they come in on a stretcher and they got the pressure bags and stuff laying in the bed, so it's not upright, right?
Yeah.
So then you can push air in, so
Yeah.
then you're like pulsing air into the
Yeah. No, I've seen that
artery.
too. That makes a lot of sense.
always
Did you
try to
guys hear that?
keep that free there.
Amber, did you guys hear that? What Jeremy was saying?
Like you put it in your pressure bag.
Yeah.
You can prime it in a way that so that bit of air
It's
just
all
goes
gone.
up and out. Yeah.
Really good idea. Wow. Look at you, brains and beauty. All right. Well, that's it for today.
So I have a couple websites. If they would-
Oh yeah. Yeah, tell them.
So I last night got on YouTube and I was watching some videos, and the first one I watched was for the Novolong, and it's how to prime it from the manufacturer. And the website on YouTube is the number 1 and followed by the letters UCIHULP. So that's a website for the Novolong.
We can send it out in the email too.
Yeah, and then the other one on YouTube is called Cardio Help Playlist. And you just type in Cardio Help Playlist. It has 11 separate videos. So it goes through the first part, second part, third part. Probably the longest one is 5 minutes, but that one's very helpful on how to prime the Cardio Help. I didn't find any on the CentraMag. I just found those 2. So that's just a little FYI.
I think the CentraMag would be hard because everybody utilizes different oxygenators with that system. So that's probably why. Yeah. But there was another thing I wanted to see too, and I forgot. We can send that in the group chat, all those.
Okay.
If you want to provide them, that would be
Sure.
great, Lena. That's awesome. Lena's been doing a lot of research. She's awesome with that. So
Yeah.
any insight you can give, I'm all for it,
Okay.
especially because we have a new hire. Zach starts at the end of this month. So even if we can include that for him, I think that would be great to catch up on. Even Jeremy, since he's coming back. It's probably good for him to speak to or jump in. Even those wet labs and sims you can always jump in on. Also, both of you, anybody can. With Zach and hang out with him and do all his stuff with him. So you'd be actually redoing exactly what you did in your training.
Which is probably good for me.
I think, I
Yeah.
mean, I even like doing it. I like refresher. I'm sure Jerry and Dan and all of them
Yeah.
can agree to that. It's nice just coming in because you might cannulate once. It might be 6 months till you actually get to do it again. So it's just nice to always jump in and do a refresh button. But then there's always these little things that people forget about. So it's always good to stay on top of that as well. Does anyone else have any other questions?
No, thank you.
Yeah, of course. Thanks for joining. If you joined, can you just text me and let me know that you did? Because I can't see it. I can see some people, but not everyone. So I can give you credit for today.
Yes.
Thank you.
You're welcome.
All right. Thanks, guys.
Wish us luck in the elevator.
Were you stuck with Jeremy and Lena?
No.